So we are about to go live, I think. And yeah, we are live.
Yeah, hi everyone. I welcome all of you to this 83rd masterclass. And I was discussing this was with one of the colleague today in the afternoon when she had a doubt about the protocol. And then we realized that we have not done a masterclass on how to do the stimulation protocols in low AMH cases. So then we decided we should do this because I think most of us face this therapeutic challenge of stimulating patients with low AMH. And the most frustrating things are like canceling the cycle, failure of fertilization, failure of getting blastocyst or arrest of the blastocyst, and also failure to get even an embryo to do the transfer and canceling the embryo transfer. So I hope this lecture throws some insights as to how to troubleshoot and also how to reduce the cancellation rates, at the same time increase the pregnancy rates in patients with low AMH. So over to you, sir. Not audible. Not audible.
Before I start this session, let me tell you that this session will only help people who are actually practicing self-cycle IVF a lot. Okay, if you are practicing at a place where you think switching gametes is a way of life, then I really think you should log out of the lecture right now itself, because nothing which I speak is going to make any commercial sense or any viable business sense for you. Okay, it is much more easier to just go take donor eggs, get 7 8 eggs or whatever the government has approved. Okay, um, give a patient somebody else's genes, okay, and let them become pregnant. When you are discussing low AMH, one thing we must understand, this session is going to be focused only on IVF. But remember one thing, in young patients, we have discussed in our masterclass number 21 that if you have low AMH and you predominantly divide patients who want to conceive naturally at two age groups, age less than 33, age more than 33, okay, for Indian women, you can check that masterclass and I think you will get a beautiful insight on that. Okay, um, so all protocols which I will be speaking about, we all know that there are multiple protocols, correct, for patients with low AMH. The reason why there are multiple protocols is because none of them seem to work very nicely in every patient. We can't really tell that. And I think as a unit which was almost exclusively practicing self-cycle IVF for the last almost 6 years, these type of insights and these type of sessions for IVF are going to be very good, because we have taken certain unconventional approaches to stimulation, which I will be sharing. And for people who think that, they are not making any sense, I will be sharing the logic also. Okay, why I am doing a particular protocol. And we have tried to standardize how to stimulate low AMH for IVF, just like how we have standardized how to stimulate them for natural cycle and IUI protocols. Okay. So I will just start with the screen sharing. It's audible, no? I mean, visible, no? Shilpa madam? Okay. So here we go. Okay. We want to speak of low AMH in IVF, ICSI cycles. Okay. So obviously, whenever we try to talk of low AMH cycles, we were just discussing with Dr. Shilpa that what are you going to give more importance to? Are you going to give more importance to AMH, or are you going to give more importance to antral follicle count, or are you going to give more importance to age? Okay. So remember one thing, if I have to point out of these three, then age is the most important factor. Second most important factor is AMH. Okay, and third most important factor is antral follicle count for that particular cycle. This point that though AMH is overall important for that particular cycle, antral follicle count is much more important. We have already discussed in our previous class on stimulating at low AMH for natural intercourse. Okay. Now, how do you divide? Let's say you have a patient of low AMH who is going to require IVF only. Okay, so how do you divide these patients into using a particular type of protocol? So please understand one thing. These protocols, okay, we have divided into 2 or 3 subcategories. Okay, it would be a little longer masterclass than my routine masterclass, but I will try to keep it very, very concise. Okay, and probably I will try to answer more questions. Okay, so basically, you are trying to look at somebody from an age perspective. Age of the lady less than 32 years. Age of the lady more than 32 years. Age of the lady more than 40 years. Okay, so when I say more than 32, that is between 32 and 40. Okay, let me just draw it very clearly because otherwise it will be a confusion in this class. Okay, fine. So we have these 3 initial categories based on whom we are going to be treating all these patients. Okay, now inside this category, we have 2 categories. AMH more than 0.5, AMH less than 0.5. Okay, so I will just shift age more than 40 years little this side so that I get some more space. Okay, between the 32 to 40 years also, I will just shift a little. I'll just make some space here so that all of you can see it nicely. 32 to 40 years and less than 32 years. Okay, so we have divided it into AMH more than 0.5, AMH less than 0.5. Again here AMH less than 0.5 and AMH of more than 0.5. Okay, simple divisions, no confusions. Correct, no? Fine. Now you have got 6 categories basically in whom you are going to stimulate. Usually, when AMH is more than 0.5, your antral follicle count will be more than 3. Here the antral follicle count will be less than 2. Okay, antral follicle count will be more than 3. Antral follicle count will be less than 2. Same, huh? Antral follicle count will be more than 3. Antral follicle count will be less than 2. Okay, now you are going to do IVF. So before you do IVF, the most important thing which I want to tell is about counseling. Forget the IVF. Remember the counseling. Remember, whenever a patient is going to undergo an IVF stimulation with low AMH, dual stimulation protocols, or embryo pooling, which may indicate multiple stimulations, is going to be your protocols of choice. So basically, this has to be your primary counseling because you need to counsel the patient about the time involved. You need to counsel the patient about the cost. You need to counsel the patient about the injections, which are involved as a part of the double stimulation protocol. Second, very, very important, success rates. Because people who are trying self-cycle, one, they will be trying self-cycle thinking that, okay, if I try, then my life will be good. Okay, so antral follicle count more than 3, AMH 0.5, same. We'll just divide the success rates as to what should you, we give this in writing. Okay, so probably you can also start giving all these things in writing. Should you think, you will be in a state to do all that. Fine. Here, the success rate is going to be usually 30% because the age is less. Here it is 20%. Between 32 and 40, it is 20%. AMH less than 5, it is 10%. It's very, very simple. Huh? Actually, here it is 10% and here it is 5%. Just, of course, these parameters are not exact success rate parameters, but when I talk of these success rates, I'm trying to talk of live birth rates. Please understand, my success rates will always be as live birth rates. I'm a non-commercial IVF clinic. Though I may be expanding my centers, but I'm absolutely non-commercial. So it doesn't make any sense for me to tell my patients that, oh, fertilization is 94%. So that is your success rate. All these things doesn't really matter to us. Okay. Another important thing, okay, which Dr. Shilpa has discussed, cycle cancellation rates. And the fourth important thing which you should be counseling the patient about is embryo formation. Okay, fine. Cycle cancellation rate is very, very simple. When the age is less than 32, cycle cancellation rate is usually less than 10%. Between 32 and 40, the cycle cancellation rates are usually approximately 15%. And here it is approximately 25%. This is numbers based on my statistics. I do not follow the global statistics. And if you look at my statistics, then we are approximately stimulating more than 100 patients in a month, okay, who are having low AMH. So we have a good volume, and I am talking based on this volume. All right. Embryo formation rate in women who are less than 32 years of age, 32 and 40 and more than 40. Now, this is going to be a shocker answer. So the thing is, it is unpredictable. Okay, because this embryo formation is not just dependent on low AMH, it is going to be dependent on a lot of other variable factors. Okay, so please keep this in mind, because these are our standard counseling points which we counsel before we actually do the treatment for these patients. Okay, now once you have done this entire counseling to your patients, then comes the question of actually choosing a protocol for these subcategories, okay, and then stimulating. Now one can ask, why did you make these subcategories when you want to individualize? The thing is, when you're stimulating so many patients, I want all my staff to stimulate in the same manner. Okay, I do not want anybody to go wrong. Protocol, pre-treatment, dose, trigger, freeze-all, luteal phase support. These are some of the important things which we should know. Now, always remember, the protocol is going to be dual stimulation protocol as a standard protocol. Okay, this is absolutely standard protocol. Many occasions you can do a dual stimulation with something called as random start protocol. Okay, it's very easy. You can go through our masterclass on random start protocol, and you will realize that you can do one random start protocol, you can do the egg pickup, and you can do the other random start protocol. That becomes a dual stimulation. Same thing you can apply for embryo pooling as well. All right, absolutely no confusion in this thing. When the pre-treatment, what all pre-treatment has to be given? So we have standardized this as 2 shots of GnRH antagonist to all patients, to all low AMH IVF patients, irrespective of the findings. Okay, no confusion. We have standardized it at this way. You can really change the way you want to change it. All right. Now, this part is important. What are our standardization of dosages? So we have already discussed this many times, but I will write it down for all of you again. In this category of patients, age less than 32 years, our dosages are simple. It is always going to be letrozole 2.5 plus HPHMG 300. In this category, 32 to 40, here it is the same. It is letrozole 2.5 plus HPHMG 300. Here, antral follicle count less than 2 and antral follicle count less than 2. So again, even in this lady, it is going to be letrozole 2.5 plus HPHMG 300. Okay. Now in these 2 categories, we will do something which is slightly different. I will just label it in green arrow because this is slightly different. We try to give incremental letrozole plus 150 HPHMG. Same here, incremental letrozole plus 150 HPHMG. Okay. Trigger, absolutely standardized for all patients. That is 0.3 GnRH agonist trigger. Okay. We usually use decapeptyl. That is a triptorelin. Okay. That is what we use. So I'm just sharing it. Freeze all, yes for all. All categories is freeze-all. Okay, because all categories is dual stimulation, all categories is almost random start. So when you do this, your answer has to be freeze-all. Neutral phase support is absolutely standard progesterone gel, 8% plus Dufaston. Okay, these are the two things which we have given in our LPS for a long period of time, and we do not change it at all. Okay, now another important thing after you understand this, because this type of standardization probably you may not get to see so frequently. I will again delete all the other parts which you don't need to know. All right. I will discuss something about pre-treatment with testosterone gel, because that is important. Everybody loves it. Even if they don't understand anything about it, they love it because somebody is using it who is proclaiming it to have miraculous results. So let's switch on to adjuvants very fast. DHEA, CoQ, antioxidants, testosterone gel, 0.2%, ovarian PRP, bread and butter for majority of the people, and stem cell therapy. Okay, these are the additional therapies which you need to know. So let me just tell you with these three guys, I'll write it big enough so that people understand. No role unless you want to have some company who is sponsoring your Eshere or Isar or other such trips. Otherwise, all these things has got no role. Testosterone gel 0.2%. Might help is the most important word, might here. You can give it in the previous cycle. Okay, 21 days. Anytime if you give in for 21 days, it is okay. All right. PRP. Fortunately, no company is making PRP. So I can proudly say it has got no role. Okay. Even if you have had experiences, I know of 90% of the IVF consultants who have had wonderful experience with PRP. Okay. But the thing is, fortunately, the conference which you attend, Eshere, it has itself said it has got no role. Okay. So I'm happy that it has said it has got no role. I personally think stem cell therapy has only got very limited role, because at the moment we do not know which stem cells work. At the moment, we must tell you very categorically that people who are marketing about adipose cells has no output. So don't fall prey for such type of practices. This is going to work only in 10% of the patients. It will not work in patients beyond this. And it will actually only work when you have antral follicle count of less than 2. For this category, antral follicle count more than 3, it has no role at any age. Okay, it will only work when antral follicle count is less than 2, and predominantly in this patient where antral follicle count is less than 2 and age is less than 32. That is where it will work the best. In all the other patients, it has got very limited role. And please remember, all these guys, okay, are considered to be parts of experimental therapies. So one has to have their own genetic laboratory like how we have, which is a proper genetic laboratory. You can't really have some makeshift, arrangement, and you can say that somebody is getting some phenomenal results out of all these things, because if you are getting no, then you will qualify for a Nobel Prize. Trust me. Okay, and I'm 100% sure none of us will qualify, because it is actually got no role, and it is going to be proven that unless we find thicker stem cells, okay, till the time it will really have no role. Fine. So just keep that in mind. Now, before I conclude, I think I've spoken for 15 to 20 minutes. Just before I conclude, just something on pre-treatment with estradiol valerate, okay, in any of these cases for cycle regulation. No much benefit. In fact, when you give pre-treatment with estradiol valerate, it increases the dose requirements for HPHMG, okay, or with recombinant FSH. Now, I am not a big fan of recombinant FSH. Can you try anything special? Okay, so in these guys, one where antral follicle count is less than 2, I think you can give some importance to low dose HCG protocol. I actually started doing low dose HCG protocol around 5 years back. Then I gave up on it because I was making some mistakes. Then I heard somebody, not somebody, he's Dr. Paresh from DISA in Gujarat, and I spoke to him and he modified my protocol. And ever since we have started using it, we have now used it on 577 patients. Okay, so far. And I think it is very good for this category of patients where you want to do budget self-cycle cases, okay, for low AMH patients in IVF, okay. It will really cut down the cost of your stimulation, and I think it is very good. The outcomes are good. One thing I can tell you, you will get lesser oocytes, okay, with low dose HCG protocol, but you will get excellent embryo quality, okay. And we have discussed the mechanism of action in our first masterclass itself, so you can go through that. All right. So that is something which you can probably try. Any adjuvant which I think may benefit, because a lot of people love to talk about growth hormone, and people have got miraculous results even with that. So people love to talk about growth hormones, and people really love to talk about pyridostigmine, okay, which is a growth hormone surrogate. So I think pyridostigmine 60 mg tablets to be taken twice in a day from day 2 of stimulation till day 12, basically till the day of trigger, has got much more better effect as compared to growth hormone stimulation. Okay, this is my personal opinion that growth hormone has got extremely limited role and benefit. If in case you want to exploit the role of growth hormone, then probably you can start using pyridostigmine. Much more cost effective, much more safe. The only problem with pyridostigmine is patient can experience twitching. Okay, that means they can experience some amount of extrapyramidal symptoms with problems over their lips and all these types of things. And one can probably try. All right, just keep that in mind. But apart from this, majority of the things which we have tried and we have burnt our fingers, nothing really works. I am not a very big believer of clomiphene citrate. A lot of people love using clomiphene in low AMH. I don't believe in it so much, because usually what happens is the basal FSH in these guys is already high. Okay, by itself. Okay, the clomiphene will be even more problematic if you have low AMH with obese patients. Okay, and I don't really like using it, but I know of people who use it and who have got great results, right? I know that, and of course, as a rule, we just wish them all the best. But that doesn't mean that that is a superior protocol. Okay, I personally don't think it is a superior protocol. It is just like somebody likes to use, let's say I like to use dufaston, right? For example, I have not switched to any of the biosimilars which have come in contrast to dufaston, which are half the price. I have not switched, right? There are people who have said that, "Arey, this tablet is more effective than dufaston." That's okay. But same thing happens with people who are using clomiphene. The ones who like to use clomiphene, they really love it, and it might be difficult for them to switch. Okay. So with that, I conclude, and maybe 2 questions or maybe 3 questions from Shilpa madam. Not 18, but 2 or 3 is okay, because I think we have covered most of our questions.
Yeah, most of it is covered. So tell me about obesity and low AMH. I mean, do you see it frequently? Is it increased in the recent times? And is there anything that you would tweak to increase the dosage of gonadotropins in such cases?
See, I'll tell you one thing, madam. The dosage of gonadotropins, we are actually overdoing it, I think. Okay, I personally think. That's why I have written in some 2 cases which I mentioned, when we divide this flow chart, we actually give it at only 150. Okay, because beyond, I do understand that you need a slightly higher HP HMG to go inside to actually ensure that the oocyte allows the cumulus to get matured. Okay, but you don't need a dose higher than that, because there are not so many receptors which are present at that stage of recruitment. Okay, so I don't increase the dosages, very honestly. I just keep it standardized.
What do you mean by incremental increase in the dosage of letrozole?
So that is, you give letrozole 2.5 BD on the first. So that is 5 mg of letrozole basically for the first 3 days. And you make it 7.5 mg for the next 3 days.
Okay. And see, we see a lot of asynchrony. Even if there are 3 follicles, we see
So
asynchrony.
that's why I told you, irrespective of anything what you see in low AMH, kindly standardize it with pre-treatment antagonist. No matter what you see, even if follicles are small, you should give 2 dosages of pre-treatment antagonist so that next time you don't have to chew your own head.
So see, there are 2 things here when we are discussing about low AMH. One is, do we increase the number of follicles, or do we increase
Never.
of the follicles? So among these, which you think is more practically doable? Or you think you are just like, I mean, you are just doing with what is available at that point in time, and you can't really change much about the de novo nature of the patient.
The last part was correct. You can't really change much.
And you didn't mention about the TVOD, which is your favorite.
I didn't mention because let me finish 200-300 patients, then I will talk.
Yeah. So you see a low response.
But I'll tell you it is very good. Okay. I'll tell you it is very good.
Thank you, sir. I expect. So you see, you have cancelled a cycle, and then
wait for 7 days and restart the stimulation.
Yeah. So in such situations, so what is it that you are going to change, or you are going to stick to the same protocol what you have written?
Same protocol. It's just that new wave of ovarian recruitment would have occurred in 7 days washout window. You want to stimulate that new wave.
So tell me, you're going on telling about dual stim and random start protocol and all this. So you really believe that the follicle recruitment happens in waves at multiple times during the cycle, and you're trying to utilize that opportunity to stimulate?
That is the same protocol followed in random start as well. Same theory. And as long as it works, it must be working in that manner only.
So in situations like previous ovarian surgery, endometriosis, so in these, do you see any difference in terms of like oocyte quality or the blast?
Not after the surgery is done.
Yeah, I meant after the surgery. So in these situations, is there anything differently that you would like to do?
No, almost the same.
So what is the max dose? I mean, you don't go beyond 300, 375.
300. Never above 375.
So that, but there are people who say that 450 is okay to do it. So I mean, is it by experience that you have stopped at 300, 375, or you think
so do you want a textbook answer or Jai Mehta answer?
Answer. It's okay.
See, remember one thing. According to textbooks, any dose more than 375 is actually going to do more harm. Okay. And you will start getting oocytes which are slightly more granular. Okay. Because though the receptors will take only that much. Okay. What that receptor is scheduled to take. I think it increases the amount of peripheral androgen. Okay. Which is in the circulation, which is not very good. Okay. I don't give. I have seen so many people in Bombay who give 900 international units. Okay. And that's a very common. Yeah. It's a very common practice.
Total dosage is 900 for a cycle or 1 day?
1 day, 1 day.
Wow.
So, see, once you exceed a particular dose, you give 900, you give 9,000, you give 90,000. It doesn't matter. The number of follicles are the same. Yeah. Okay. So if and the number of receptors which are present on those follicles are the same. Remember one thing, these receptors will keep on increasing once the follicle grows from 12 millimeter to 18 millimeter. In that window, the number of receptors would really shoot up. Okay. So it is at that point in time where your density of the drug available should be maximum in the blood. All right. For you to actually get the maximum benefit of post recruitment. All right. Which is why you add antagonist after 12 millimeter and not before that. Before that, there is hardly anything. What you will give antagonist? Correct. After that 12 millimeters only, that receptors grow, where the antagonist will at least go and hide somewhere. Correct. So that is the logic. Once it is occupied, you don't have to think much about it. Very honestly.
what about just modified natural cycle, like just giving letrozole and doing a pickup without actually adding
Very
gonadotropin?
good. Very good.
You
When
do it.
antral follicle count is 1 to 2, it is very good. Your entire stimulation will finish in 1 lakh rupees.
And pickup and transfer too. I mean, what are you saying?
Yeah, everything.
Yeah. Okay. So what about sorry, I got distracted. Okay, so we are talking about Posedion group 3 and group 4 as low AMH that you are saying. So you changed the dosage in that particular segment where the AFC was less than 2 and AMH
Yeah.
was less than 0.5. So
Yeah.
I think having these two as a criteria, you did not take age as a particular criteria.
I did. The most important criteria was age there.
Oh, but you said the same thing for between 32 to 40 and also above 40.
More than 40. Correct. This is for Indian woman, not for Italian woman like Poseidon.
Okay, so in these cases, how do you kind of what do you individualize? You don't individualize.
No, don't individualize. See, that is the problem. If you go and individualize, no, then you will give 12.5 units of FSH. Okay. Don't do that. If in case your nurse makes a mistake, instead of 12.5, she makes it 25, even if the patient does not become pregnant, she will blame that extra 12.5 units of FSH or HPHMG for her lack of pregnancy. Don't do that. The minute you get more busier in practice, standardize things.
See, blastulation rates are low when we deal with patients with low AMH. So do you recommend to transfer on day 3 in
Only
case?
blastocyst.
So what don't you think the natural milieu that inside the uterus is better than your lab and lab environment?
It may be better, absolutely no denying that. Can't really compete with nature. But one must remember one thing, that it can also be reverse is true, right? That because of low AMH, the endometrial milieu itself is not good enough, or the fallopian tube milieu itself is not good enough for that oocyte to become a blastocyst inside that. So you might as well give an opportunity to that oocyte to become a blastocyst in the controlled laboratory environment. That can also be true.
Good one.
What you spoke is some paper. Somebody would have published this milieu, that milieu. But how do we know? How do we know the fallopian tube milieu? Okay, why do we always think that fallopian tube milieu, which we say as human tubal fluid, correct? And we try to extract and we make our culture media based on human tubal fluid. And that is a culture media. If you ever read your culture media, it is standardized for HTF, human tubal fluid, of normal woman through their washings, through chromatographic separation, okay, of that tubal fluid for women who are less than age 32 across the world. Okay. And then they have added recombinant factors inside that. So they don't have to go and extract that. But the first milieu was standardized for younger women. So that means if the women are getting old, and there is something in the tubal fluid which is changing or probably causing ectopics, it must be something related to that oocyte, or to that oocyte, the autocrine paracrine factors which the cumulus cells are releasing, which is causing that to happen. So why should we leave that to chance, is what I think.
Wow, this is something I had never thought about. So, do you believe in getting more number of follicles, which will lead to increase in the number of good embryos, or you think some patients are having like so many oocytes and we get a good recruitment of follicles, but they still end up with no embryos?
Yeah, happens very commonly, no? So we must try our efforts to get all the follicles which we see, and all the follicles which we see should ideally reveal to us a metaphase 2 oocyte, because one additional metaphase 2 oocyte can probably give us one additional embryo, and that one additional embryo can probably add to our success rates. That is right. But then, madam, in practical life situations, if you see, it is not so easy for us to achieve that for all patients.
So do you use a double bore needle wherein you flush the follicle and then you take it out in cases where there is low AMH because you don't want to miss out on the oocyte?
Does anyone use double bore needles anymore?
I don't know. I just asked for the
I
completion of.
think they have been out of production.
Really?
Yeah, I think they've gone out of production.
No, you would have ordered your needles 1 year back. No, how will you know? You would have ordered some 5,000.
I think they are out of production, but still, I mean, I don't think it is important.
Hmm.
In fact, that will cause displacement.
Yeah. Yeah. Okay, you didn't speak about recombinant LH in these 83 master classes that we have done.
I
So
don't speak of things I can't afford.
you can't say that. You have to answer scientifically. Like, is it because you don't believe in it? You have not used it? You don't have enough experience to talk about it? Or you think Indian women can't afford that thing? Indian IVF specialists can't afford that thing? Or you think it is all like, again, a marketing trick?
See, we are Indians, okay? And we will always come up with practices. If some American or a Britisher comes up with $5,000 ka product, no, we will give the same effect in $2. Okay, the rest $4,998 is profit. That is called business. So instead of using recombinant LH, start using low dose HCG. Superb it is. Same effect it gives. Same thing it does. Okay. The only thing is recombinant LH. The name is so good. No, it sounds like some Italian son. Luveris. So you will feel, oh, what a great product. But apart from that, nothing great in that.
Hmm. Yeah, I think I'm done. Anything else you want to add? Did I miss anything? See,
No, I apologize. This was a little long class, everyone. But this is a very important topic also. So that's why.
tell me, this low AMH, the frustrating part is the cyst formation and the.
Aspirate it. If the estrogen is less than 50, aspirate and go ahead.
But why should we aspirate if the estrogen is less than 50? I mean, just
Still,
ignore it.
madam, it will keep on growing, no? And it will form that simple cyst. If by mistake they go to somebody else, they'll say, "Arey, cyst mein tumhara chalu kar diya stimulation." Like that, they will say. So better is you aspirate.
Yeah. Okay. It was wonderful. I think there were so many points which was very new. And I know because I read quite a bit. So thank you very much for all your inputs.